I would like to start with the first oral abstract presentations by Dr. Christopher Alba from United States on the cost effectiveness of broadly neutralizing antibodies for HIV prophylaxis for all infants born in high burden settings.
Good morning, everyone. Thank you for the introduction, and on behalf of my co-authors, thank you for the opportunity to present this work. I have no conflicts of interest, and just to note that this work is under embargo for AIDS 2022. As this audience is well aware, and we just heard this morning, vertical HIV transmission persists despite the continued expansion of maternal antiretroviral therapy and other prevention efforts. UNAIDS estimated that 150,000 children under the age of 5 acquired HIV in 2020, with similar numbers being reported for 2021. Approximately 2/3 of these children had mothers living with undetected HIV at delivery or acute HIV while breastfeeding, and therefore are not protected by current prevention efforts that target children who are known to be HIV exposed. Broadly neutralizing antibodies, or bNAbs, could supplement existing prevention approaches. Anti-HIV bNAbs have demonstrated efficacy against perinatal and postnatal acquisition in non-human primates, efficacy against acquisition of bNAb-sensitive virus in adults, and safety and tolerability when given as injections to newborn infants. Our objective was to estimate the potential clinical impact and cost-effectiveness of offering bNAb HIV prophylaxis to infants born in 3 country settings: Côte d'Ivoire, Zimbabwe, and South Africa. To do so, we used the cost-effectiveness of preventing AIDS complications model, or CPAC, a validated computer-based HIV model to simulate individual infants from birth to death, accounting for vertical transmission risks, pediatric HIV prophylaxis, diagnosis and treatment, as well as associated care costs, with our full model details available online. To evaluate bNAb strategies, we first modeled the standard of care in which infants with known HIV exposure were offered WHO-recommended oral antiretroviral prophylaxis. We then modeled offering bNAbs to one of 3 target populations, and this is in addition to the standard of care. In green are infants with known WHO-defined high-risk HIV exposure at birth, abbreviated HR-HIV. In blue are infants with any known HIV exposure at birth, abbreviated HIV. And in purple are infants irrespective of known HIV exposure, abbreviated ALL. Infants in this target population were offered one of 3 dosing approaches. Again, this is in addition to the standard of care. 1 dose at birth, 2 doses, once at birth and once at 3 months, or extended dosing, once at birth and once every 3 months thereafter for up to 18 months while breastfeeding. To model specific countries, we parameterized the model with maternal HIV prevalence at delivery of 2.6% in Côte d'Ivoire, 12.3% in Zimbabwe, and 33% in South Africa. Maternal knowledge of HIV, ART uptake, maternal incidence postpartum, and HIV-related care costs are just a few other examples of the model inputs that are setting specific. In terms of bNAbs, since we acknowledge that they're still under clinical investigation, we made the assumption that an approved bNAb product would have 70% efficacy against intrapartum and postnatal HIV acquisition based on existing data on efficacy against sensitive virus in adults, as well as in vitro neutralization coverage data. We assumed a 3-month effect duration following each bNAb dose based on existing infant pharmacokinetic data led by many impact investigators, an uptake of 56 to 96%, which is age-specific and country-specific based on the uptake of other routine vaccinations, and a cost of $20 per dose based on monoclonal antibody production and vaccine delivery in low and middle income countries. Since these are assumptions, we varied them widely in sensitivity analyses. We projected cumulative vertical HIV transmission, average life expectancy, and average lifetime HIV-related costs, and calculated an incremental cost-effectiveness ratio, which we present in dollars per year of life saved. We identified a strategy as cost-effective if it resulted in the greatest clinical benefit and was cost-saving compared to the current standard of care, or had an ICER of less than 50% of a country's annual GDP per capita. A strategy was considered dominated if it was either A, less clinically beneficial and more costly than another strategy, or B, less clinically beneficial than a strategy with a lower ICER. We evaluated all combinations of target populations and dosing approaches, but we're only going to be presenting the non-dominated strategies for simplicity. Our model suggests that bNAb strategies were projected to reduce vertical HIV transmission by 24 to 43% compared to the current standard of care and be cost-effective. Just as a reminder, the abbreviations for the strategies: HIVE means a strategy targeting infants with known HIV exposure at birth. Extended means a bNAb dose every 3 months for up to 18 months while breastfeeding. And the third strategy, all one dose plus HIVE extended, is actually a combination of offering all infants 1 dose at birth and then extending bNAbs just for the infants with known HIV exposure. In Côte d'Ivoire, bNAbs were projected to reduce vertical transmission from 8.4% in the standard of care to 5.5% with all extended, and HIVE extended was cost-saving because of fewer infants acquiring HIV, thereby averting a lifetime of HIV-related care costs and adverse clinical outcomes. In this case, HIVE extended, highlighted in green, is cost-effective because while there exist other strategies that have greater clinical benefit, their ICERs, which are highlighted in yellow, are above the threshold of 50% GDP per capita in Côte d'Ivoire specifically. In Zimbabwe, bNAbs were projected to reduce vertical transmission from 9.5% in the standard of care to 5.7% with all extended. And in this case, HIVE extended was again both cost-saving and the cost-effective strategy with an ICER threshold of $607 per year of life saved. And in South Africa, bNAbs were projected to reduce vertical transmission from 4.4% to 2.5% with all extended. In this case, HIVE extended would continue to be cost-saving as it was seen in the other settings. However, all extended would be cost-effective because it has the greatest clinical benefit and its ICER of $882 per year of life saved is below the threshold of $2,828 specific for South Africa. And we believe the reason why all extended is cost-effective in South Africa and not the other settings is partially due to higher maternal HIV prevalence and incidence, as well as the higher GDP per capita. bNAb infant prophylaxis would remain cost-effective across a range of efficacies and costs. On this heat map, we range bNAb efficacy from 10% on the left to 100% on the right, and from $5 per dose on the bottom to $100 per dose on the top. And each square corresponds to the cost-effective strategy at that specific efficacy and cost. So if it would be green, that means the strategy is targeting infants with known high-risk exposure. Blue is targeting infants with any known exposure. And purple, again, is targeting all infants. Under our initial assumptions, we found that at 70% efficacy and $20 per dose, that HIVE extended would be cost-effective, which we showed in the previous table. And as we vary costs by moving up and down, or efficacy by moving side to side, we find that HIVE extended would continue to be cost-effective unless bNAb efficacy were as low as 10% efficacy, in which case HIVE 1 dose, represented by that light blue, would be cost-effective. As we fill in the rest of the heat map, we find that at most combinations of efficacy and cost, targeting infants with any known exposure would be cost-effective in Côte d'Ivoire. We repeated this for Zimbabwe in the middle and South Africa on the right. And in Zimbabwe, we find that at most combinations of bNAb efficacy and cost, targeting infants with known HIV exposure at birth, again represented by shades of blue, would be cost-effective. And in South Africa, where maternal prevalence is the highest among the 3 modeled countries, at most combinations of efficacy and cost, targeting all infants would be cost-effective. We acknowledge that our analysis has limitations. For example, characteristics of bNAb infant prophylaxis in actual clinical settings remain unknown. However, bNAbs are projected to provide good value throughout plausible cost and efficacy ranges. And we did not explicitly consider health equity, such as the potential level of partner funding, as well as the cost-effectiveness threshold that would correspond with the decision-making with governments and the partners. In conclusion, offering bNAbs to infants with known HIV exposure would be cost-effective in Cote d'Ivoire and Zimbabwe, and offering bNAbs to all infants would be cost-effective in South Africa, where maternal HIV prevalence and incidence are relatively higher. Cost-effective bNAb strategies would substantially reduce projected vertical transmission compared to the current standard of care, and the potential clinical impact and cost-effectiveness of bNAb infant prophylaxis should motivate further bNAb research and development. I'd like to acknowledge our larger CPAC team, collaborators, and funders. Thank you.